Greetings, everybody, and welcome to the sixth monthly journal club with authors by Oral Pathology 360. I'm Dr. Mandana Donahue, founder of Oral Pathology 360 and the technical host of today's event. To get the most from this event, please set your YouTube resolution to high. And although you can watch this from within many platforms, it is best if you come to YouTube itself because from there you can type in your questions and you can actually interact with us and interact with the author, Professor Skalova. Now, also, if it's your first time, before I forget, please hit the subscribe button and also turn on notifications so you will always be able to catch our programs. Now, let me bring in our host, Dr. Puyan Amini Shakib, who will introduce our amazing guests for today and start the program. Welcome, Dr. Puyan. It's nice to have you here again.
Hello, everyone. Thank you, Dr. Mandana, for letting me have this joining this meeting. It's a great pleasure to get started the sixth online interactive journal club with authors. Uh, at the beginning, I would like to congratulate you, Dr. Mandana, for the fourth anniversary of the Oral Pathology 360. And I would like to express my sincere appreciation to you to promote oral pathology around the world and keep going.
Thank you so much. And congratulations to you too. You are very much a part of this. Thank
Well,
you.
welcome. And I would like to quickly get started the meeting. The name of the article is update from the fifth edition of WHO classification of head and neck tumor salivary gland, and it's a great honor for us to host Professor Alena Skalova. I know no need to introduce her, and it's a great pleasure for us to have her. She's well experienced and world renowned professor on head and neck pathology. And I would like to express my appreciation to you, Professor Skalova, for accepting my invitation to share generously your experience and knowledge with us. Thank you.
Thank you so much, Dr. Puyan. It's pleasure on my side. I'm looking forward what will happen. Thank you so much, everybody.
Okay, and I would like to thank Dr. Krishna from RU HS College Dental Sciences of India. She kindly accepted my invitation to supervise two talented, enthusiastic residents and be a part of discussion panel in this program. Thank you, Dr. Krishna, and I would like to ask you to introduce your residents.
Yeah. Thank you, Priya sir, and thank you, Mandana ma'am, for this opportunity. I'll be introducing Dr. Dipanjali. She's third year resident in oral pathology, and Dr. Kriti Agarwal. She's second year resident in the Department of Oral Pathology, College of Dental Sciences, Jaipur. Over to you, ma'am.
Okay, great. And I know a lot of participants have reviewed the valuable article meticulously. And let's quickly go to the first video by, I think, Dr. Dipanjali and Dr. Mandana. The stage is yours.
Yes, and here is the video.
Good morning, everybody present today here in the meeting. I am Dr. Dipanjali, resident of Oral and Maxillofacial Pathology, and I'm here to discuss an article on the update from the fifth edition of the World Health Organization classification of head and neck tumors, salivary glands. It was published in the journal named Head and Neck Pathology in the year 2022. The title of the article is Update from the fifth edition of the World Health Organization, Classification of Head and Neck Tumors, Salivary Glands. The abstract contains 275 words and authors are Elena Skilova, Martin de Hercras, and Elimo Libo. So, coming to the introduction, the major and minor salivary glands are associated with a remarkable diversity of neoplasms. The number of already existing entities which show considerable overlap of histologic and immunohistological features between different salivary glands neoplasms. And in that, only very well documented new entities have been accepted in this edition. Lacking consensus support and validation by independent investigators have not been included in this edition. This approach has led us to new additions in the benign and malignant neoplasms category. The benign neoplasm being the sclerosing polycystic adenoma, keratocystoma, intercalated duct adenoma, striated duct adenoma. In malignant, there are two variants, that is microsecretory adenocarcinoma and sclerosing microcystic adenocarcinoma. Several tumors have been omitted that does not occur predominantly in the salivary glands, like the hemangioma, lipoma, nodular fasciitis, and tumors of the hematolymphoid origin. In the WHO 2017 classification, sclerosing polycystic adenoma was in the category of non-neoplastic lesion, but in this edition, it has been shifted to the benign neoplasm category. Histological grading of salivary gland carcinoma has been shown to be an independent predictor of behavior and plays a very important role in optimizing therapy. Still, most salivary gland carcinoma have an intrinsic biological behavior, and the attempts to apply universal grading schemes onto that are not recommended. Yet, there are validated grading systems that exist for tumors like adenoid cystic carcinoma, mucoepidermoid carcinoma, adenocarcinoma, not otherwise specified lesions. Since the last edition, molecular data has become widely reported, with many salivary gland neoplasms that shown to harbor tumor type specific rearrangements. Molecular testing of salivary gland tumors for differential diagnostic accuracy and appropriate clinical management is becoming a routine now. So there are cytological findings that have been included in most of the sections in recognition of importance of fine needle aspiration as an initial diagnostic approach. While the FNSC has emerged as an important concept in the diagnostic workups of salivary gland tumors, the architectural information is better in the core needle biopsies. Assessment core needle biopsies, they do not allow assessment of the interface between the tumor and the surrounding tissues, and thus are insufficient in distinguishing between tumors and low-grade malignancy. Yet, they are still performed occasionally, especially after the non-diagnostic aspirates. Then coming to the changes, that are the mucinous adenocarcinoma has been divided into subtypes, that is the papillary, colloid, signet ring, and mixed subtypes, and characterized by recurrent AKT1E17K gene mutation across various patterns. In this edition, various molecular alterations have been included in the sections of mucoepidermoid carcinoma, adenoid cystic carcinoma, secretory carcinoma, polymorphous adenocarcinoma, hyalinizing clear cell carcinoma, mucinous adenocarcinoma, and microsecretory adenocarcinoma. The tumor demonstrating high-grade transformation, HGT, shows an aggressive clinical course that differs significantly from the usual behavior of a given tumor type. So therefore, this phenomenon of HGT is included in the description of the appropriate entities. There are various controversies that are still not resolved in the fifth edition. They are like the mucinous adenocarcinoma and intraductal papillary neoplasm. They share a frequent recurrence of AKTVN gene, and it's still not clear whether they belong to the same spectrum. Then the questions about the oncocytic carcinoma existence. When we see the salivary gland tumor consisting of oncocytes entirely, we consider it as oncocytoma. But it's a controversy whether it's just a variant of salivary gland carcinoma or it really exists. Then we talk about the intraductal carcinoma. It can be biphasic neoplasm or it can be truly non-in situ neoplasms. Then the carcinosarcoma, whether it's a true sarcoma or just a result of epithelial mesenchymal transition. These are still the controversy that we encounter in the fifth edition. Then coming to the first benign neoplasm category, the sclerosing polycystic adenoma. It is a rare sclerosing tumor of salivary gland with a characteristic combination of histological features somewhat reminiscent of adenosis tumor of the breast. It is well circumscribed encapsulated tumor composed of proliferation of ducts and acini within fibrotic stroma, sometimes intermixed with foci of mature adipose tissue. The hallmark of the SPA is the presence of acinic cells with abundant large eosinophilic cytoplasmic granules. Then when we talk about the histological features, proliferations of ducts composed of the axini cells with abundant eosinophilic cytoplasmic granules can be seen in the figure named A. The sclerosing polycystic adenoma frequently harbors intraductal epithelial proliferations with the variable degree of atypia, which you can appreciate in the given picture, named as B. A low-grade atypia is composed of intercalated duct-like epithelium positive for SOX10 when we talk about the immunohistochemical profile. Coming to the mutations, recurrent mutations in the PI3 kinase pathway, most frequently PTEN mutation is seen, and this makes it a neoplastic nature. There are links with the apocrine intraductal carcinoma and salivary duct carcinoma. A close relationship exists between the SPA, apocrine IC high grade of SDC, and SPA may represent a precursor lesion for the development of apocrine interductal carcinoma, occasionally even SDC. That is a salivary duct carcinoma because there are similar mutations seen in the PI3K gene. Then coming to the second entity, which is benign, that is keratocystoma. It is a benign salivary gland tumor. There are multicystic spaces lined by stratified squamous epithelium containing keratotic lamella and focal solid epithelial nests that are seen. Essential diagnostic criteria being the bland stratified squamous epithelial lining without a granular layer within multicystic structure and the presence of sharply defined solid squamous epithelial cell islands, which can be appreciated in the given picture. Then coming to the intercalated duct adenoma, it is a benign proliferation of bilayer ducts with a cytological appearance, and that shows the immunoprofile of normal intercalated ducts. It is an encapsulated tumor, but does not respect the normal architecture. The IDAs are part of intercalated duct lesion spectrum together with the intercalated duct hyperplasia. The IDH and the IDAs, proliferation of small ducts are seen with eosinophilic to amphophilic cytoplasm, along with small bland nuclei. There are myoepithelial cells positive when we talk about the immunohistochemical profile. Then the intraductal adenomas, the bilayer ducts, intercalated duct adenomas, the bilayer ducts are seen with cytological appearance. You can appreciate that in the immunoprofile of normal intercalated ducts. And in the ductal structures are surrounded by periductal concentric layers of stromal hyalinization, and image shows spindle-shaped abdominal myoepithelial cell layer. At high power, you can appreciate that. In the striated duct adenoma, it is a rare benign encapsulated tumor. Ducts are lined by monolayer of cells, ducts closely opposed with with little or no stroma. It may show nuclear grooves and intranuclear pseudoinclusions and mimic the papillary thyroid carcinoma when we talk about histopathology. It is positive for S100, cytokeratin 7, and cytokeratin 5, and negative for the smooth muscle actin. When we talk about the differential diagnosis of the striated duct adenoma, Basal cell adenoma, lack of bilayering is seen in that, and basophilic cytoplasm is appreciated in the basal cell adenoma. The canalicular adenoma have beading pattern of anastomosing cords of cells, and oncocytoma, more prominent oncocytic cytoplasm will be seen as compared to the striated duct adenoma, forming few ducts and more solid islands are seen. And coming to the microsecretory adenocarcinoma, this is the malignant variant of the neoplasms, newly identified and low-grade salivary adenocarcinoma that is characterized by distinctive morphology. It is shown to show a specific fusion, that is MEF2C SS18 fusion. And out of till date, 24 cases have been identified, and there has been no recurrence or location or distance metastasis that has been reported. The SS18 gene rearrangement are unique among salivary gland tumors and are demonstrated by the fluorescent in situ hybridization. You can appreciate in the given picture small tubules and microcysts lined by flat intercalated duct-like cells and containing abundant basophilic luminal secretions, lack myoepithelial and basal cells, and the myxohyaline stroma, and these tumors, they lack a capsule and tend to show focal infiltration into surrounding tissues, leading to their classifications as carcinomas. Then the sclerosing microcystic adenoma, another type of rare malignancy. It is characteristically have a morphologically resembling the cutaneous microcystic adnexal carcinoma. Minor salivary glands only in the oral cavity, and the other mucosal head and neck tumor sites are not usually seen, and it's usually seen in the minor salivary glands. And this recognition of SMA has a new type of salivary carcinoma rather than simply a microcystic adnexal carcinoma occurring in the extracutaneous sites. So you can see the small infiltrative cords and nest embedded in the thick fibrous or desmoplastic stroma. When we talk about the histopathological pictures, perineural invasion is very common in this. You can see that in the picture B. The biphasic, whether it's a biphasic tumor, plant luminal cuboidal ductal cells with eosinophilic or clear cytoplasm, flat peripheral myoepithelial cells are seen. They lack the dense connective tissue deposition. And molecular testing for the MY gene arrangement can be helpful in the difficult diagnostic cases. Thank you. Rest will be taken up by my colleague, Dr. Kriti. Thank you very much.
Okay, great. Thank you very much, Dr. Dipanjali, for your well descriptive presentation. And let me start the discussion panel with a general question from Professor Skalova. Do you have any comment or additional description on this presentation, Professor Skalova?
I can see, sorry, I can see two questions, some comments, good morning, but there are two questions which maybe I can somehow answer or comment. The first one is related to differential diagnostic considerations between odontogenic glandular cyst and how to distinguish this from central intraosseous mucoepidermoid carcinoma. Well, these lesions are so rare that my comment is very humble. I have seen a couple of cases, and odontogenic, actually, glandular cysts do not have mammal to rearrangement, while a couple of cases of intra osseous mucoepidermoid carcinomas do have. We were successful to provide evidence of mammal to fusion using fish. So I believe the differential diagnosis is difficult, but based on general features and supported maybe by really finding more prominent proliferation of tissue and then provide mammilla to arrangement. And the second question relates to keratosystoma, which is a nice entity. Actually, it's a very, very rare. And our presenter, number one, spoke quite well about keratosystoma. As far as I know, those few cases that has been published were all located in parotid gland. So my own opinion is that keratosystoma does not exist in minor salivary glands. If you can see the question, so I believe that's it. There is a new information about keratosystoma which I already have. It's a benign, but let's be careful because this kind of structure may be complicated. I know about one case where real squamous cell carcinoma arose. Yeah, there was yeah, association of keratosystoma and real well-differentiated squamous cell carcinoma. So it definitely this entity deserves position in WHO classification, and we should be aware of it.
Sorry,
So that's it.
Professor Escalova, we will try to cover all the questions. And first of all, would you please let me know, for the especially for the young junior oral pathologists or head and neck pathologists, how do you commonly approach these salivary gland tumors? Is there any difference between the salivary gland tumors and tumors from other parts of the body? How do you apply IHC study or cytogenetic study to make a definite diagnosis?
Oh, thank you, Dr. Puyan. This is a challenging, however, so difficult question. Of course, what I know is that there are entities. We have look. WHO classification is. I believe in this fifth edition quite well done, and certain entities are really known to be only arising from minor salivary gland, while the others are located in major glands. Generally, my comment is that diagnosing minor salivary gland tumors is more difficult than, for many reasons, these
Okay.
oral lesions or tumors arising from minor salivary glands are more difficult to be diagnosed than um, for example, salivary gland tumors in parotid gland. Also, because surgeon may remove parotid gland and you see whole tumor, while intraoral tumors you quite often get just probatory excision, and there are pitfalls in diagnosing of minor salivary glands. So it's a your question, Puan, was very general. I would
Yeah.
answer that one would know the differential diagnostic possibilities, which tumor entities can occur arising in minor salivary glands, and then we have to do our best. And I believe that there is a really role for immunohistochemistry or other ancillary methods in diagnosing of minor salivary gland tumors, even more than for major salivary gland tumors. Yeah, it's difficult.
Okay, great. Thank you. And Dr. Krishna, do you have any question or comment you would like to share with Professor Escalova?
Uh, Again, ma'am, the biological entities of minor salivary gland, they're not encapsulated. So they're more scary, I think, for the patient also. What would be your take on the encapsulation or the fibrosis that we don't see around the tumor?
Okay, so that's again quite challenging question. Minor salivary glands, benign minor salivary gland tumors, as you properly, as you commented properly, not really are encapsulated. That's exactly the case of pleomorphic adenoma. Usually there is no capsule in it. So again, we have to rely on other markers than the capsule. I believe that there is a real difference between really invasive malignant intraoral tumors, even low grades, that you are trying to find perineural invasion, which is not the case
Mhm.
of benign tumors. But still, lack of capsule is a big problem. And I have seen a misdiagnosis of benign pleomorphic adenoma. Actually, it was misdiagnosed because of lack of a capsule, and there was actually um, uh, incorrect diagnosis of mucoepidermoid carcinoma. But it was not. Yeah. So in that particular case, we used testing black 1 and mammalo 2 to distinguish these entities. Yes. So there are possibilities, but you have the major thing is to rely on good H&E diagnosis and be aware of the pitfalls in different differential diagnosis, different entities. Thank you, Krishna. This is really difficult.
Uh,
Okay.
Professor Skalova,
And
Dr. Akshay,
Yes.
sir, guidelines regarding the minor salivary gland staging. That is the question that has been coming.
I see. I do not know much about this. Actually, I know that the staging is done similarly as for squamous cell carcinoma of oral cavity. That's the staging is different than for major salivary glands. Yeah, on the size of the tumor is the major thing.
mhm. I think, thank you, Professor Scalova. I think there is a difference between the oral cancer, other oral cancer, for example, oral squamous cell carcinoma and oral malignancy, to determine the T stage. I think the audience, I would like to refer the participants to the AJCC classification to recognize the how we can stage the oral squamous cell carcinoma versus salivary gland carcinoma. And one more question, Professor Scalova. At the beginning of the diagnosis of a carcinoma originating from salivary gland tissue, what kind, which immunohistochemical markers you commonly use? Some authors, some investigators suggest to use a general biomarkers, including cytocrotin 7, P63, to determine myoepithelial cells in the tumor, and then Ki67 to assess the proliferative activity of the cells. And then at the first panel, the pathologists are recommended to go to the next step and to determine the second panel to make a definite diagnosis. Do you have any algorithm or you arrange the IHC panels based on the H&E findings, and it is different from minor salivary gland to major salivary gland, or it is the same for all carcinoma of the salivary gland?
Dr. Puyan, thank you so much. This is a great question, of course, uh, because we do have access to immunohistochemistry. I like to use it, but honestly, I do have a very, very humble, very small panel of markers at the beginning, and I usually like to have two steps. For most of differential diagnosis, you just need cytokeratin CK7, P63 or P40, which is both of those are the nice nice markers, nuclear markers. So two of them, And then what I really like is as 100 protein and Soxten. I know that in many countries Soxten is not used, but Soxten in my hands is very useful marker because you really can distinguish two different groups of tumors arising from salivary tissue. Soxten positive, for example, secretory acinic cell carcinoma, myoepithelial, while Soxten negative is salivary duct carcinoma, adductal structures, and mucoepidermoid carcinoma usually. So you have two different groups of tumors. And then in special occasions are really like to see, for example, PLAG1 immunohistochemistry, which works quite fine. PLAG1, PLAG1, supportive, for example, in cellular or atypical pleomorphic adenomas or myoepitheliomas where you are not sure what it is. So it's definitely not very huge amount of markers which I use. Then we of course go for other specific immunohistochemical markers if we have, for example, what basal cell adenoma. Basal cell adenoma is relatively rare, and you like to see that it's beta-catenin positivity or LEP1 positivity. So, but in most cases, actually, CK7, P63, SOX10, S100, and MIB1, Ki67, proliferative activity, and that's it. Yeah, so that's how I use
Okay,
it.
great. Okay, great. Thank you very much. And as the last question in this part, let me ask you about an entity, carcinosarcoma. Do you believe in this entity originating from salivary gland tissue? You know, some investigator and authors believe that there is no true carcinosarcoma. It might be a carcinoma with sarcomatoid component next to each other, and
Yeah.
a lot of textbook explain carcinoma explomorphic adenoma and a part of this entity as carcinosarcoma. Do you believe that there is a true carcinosarcoma in the salivary gland tumors?
Okay, the question is a nice question, but it belongs a little bit to the second part of our presentation, to the second video. But I will happily say my opinion. In fifth edition, we somehow because we were already tired of all discussions, we just put it there as it is. So there is an entity called carcinosarcoma. Definitely, this tumor exists. Yeah, that's true. It's rare. It exists. In most cases, it's a malignant transformation of pleomorphic adenoma, or yeah, malignancy arising from pleomorphic adenoma. The only question is how to call it. If the carcinosarcoma is correct or it's not. The term is not correct. And in the next edition, it will be replaced, I believe, by carcinoma with heterologous not heterologous sarcomatoid component. So it is not bona fide mixed tumor. It's a malignancy with two components, but just one malignancy, it has been shown. So the name is a problem. Existence is not a problem. It exists.
Okay, great. And Dr. Thank you very much for your well descriptive reply. And Dr. Mandana, we are ready to go ahead to the next presentation by Dr. Kriti.
Hello everyone, this is Dr. Kriti Agrawal, second year resident. I will discuss the second half of the article which details about the new concept, variant morphologies, controversial issues and emerging entities. The first entity is intraductal carcinoma, which was originally described as low-grade salivary duct carcinoma and later called low-grade cribriform cyst adenocarcinoma. And in 2022, it is renamed as intraductal carcinoma. It is a rare, low-grade salivary gland malignancy. It is characterized by intraductal and intracystic proliferation of luminal ductal cell exhibiting solid, cribriform, and papillary patterns. Antibody to p63 protein, calponin, and cytokeratin 14 highlights the myoepithelial cell and intercalated duct phenotype demonstrate S100 protein and SOX10 positivity of luminal cell as shown in figure A and B. We can appreciate the SOX10 positivity in figure B. Figure C and D shows the subset of intraductal carcinoma with apocrine morphology supported by androgen receptor positivity. Most intraductal carcinoma shows recurrent RET gene rearrangements. NCOA4 RET fusion identified in 47% of intracalated duct type of intraductal carcinoma, while TRIM27 RET fusion observed in apocrine or hybrid type of intraductal carcinoma. Recently, K1AA1217 RET fusion, TUT1ETV5 fusion, and STRNALK fusion identified in rare cases of intraductal carcinoma with invasive growth. And in oncocytic intraductal carcinoma, BRAF V600 mutation, TRIM33 RET fusion are seen. Now the controversies. It remains a controversial issue how to classify intraductal carcinoma with invasive growth, and intraductal carcinoma is whether biphasic or not. Heading towards the next entity, that is polymorphous adenocarcinoma and cribriform adenocarcinoma. Previously, it is known as polymorphous low-grade adenocarcinoma. It is defined as a malignant epithelial tumor characterized by cytological uniformity, morphological diversity, and infiltrative growth pattern. Predominantly, it is found in minor salivary gland. Cribriform adenocarcinoma of salivary gland. It is a subtype of polymorphous adenocarcinoma present at the base of tongue and minor salivary gland. Compared to the polymorphous adenocarcinoma classic, it has higher risk of lymph node metastasis. As we can appreciate in figure A and B, it is characterized by multinodular growth pattern separated by fibrous septa with predominant glomeruloid, cribriform, and microcystic architecture. We can appreciate here in the figure A and B. Now, the optical clear nucleus seen in figure C resemble the eye of Annie visible in the cartoon picture. So, it is known as orphan Annie-eyed nucleus. And in figure A, D, we can see the S100 positivity. In 70% of classic polymorphous adenocarcinoma, PRKD1 point mutation is seen, and in 80% of cribriform adenocarcinoma, PRKD1 to 3 gene rearrangements are seen. PRKD1 E710D hotspot mutation and PRKD1 to 3 gene rearrangements are used as an ancillary diagnostic marker to differentiate polymorphous adenocarcinoma from adenoid cystic carcinoma, rare salivary gland carcinoma, and canalicular adenoma. Now the controversies is cribriform adenocarcinoma is different diagnostic category, or it is a variant of polymorphous adenocarcinoma itself. It is a controversial issue. And generally, the hotspot mutation has good prognosis, while the fusion positive cribriform adenocarcinoma is aggressive in nature. Coming towards the next entity, that is mucinous adenocarcinoma. It is a primary salivary adenocarcinoma that displays prominent intracellular and extracellular mucin and lacks diagnostic feature of other salivary carcinoma. Various histopathological patterns are papillary, signet ring, colloid, and mixed type. The predominant site is oral minor salivary glands. The recurrent AKT1E17K mutation is seen in this type with 100% of the cases. Next entity is intraductal papillary mucinous neoplasm. It is a low-grade proliferation of intraductal epithelium with mucinous component which has been proposed in analogy with the pancreatic duct mucinous lesions. AKT1E17K mutation is seen in this entity, while its differential diagnosis Sialidenoma papilliferum shows BRAF V600E mutation in 50 to 100% of the cases. Now the controversies whether intraductal papillary mucinous neoplasm is a separate entity from mucinous adenocarcinoma, possibly related to the ductal papilloma. Second one is whether it is a precursor region to mucinous adenocarcinoma, analogous to pancreatic intraductal papillary mucinous neoplasm. And third one is whether intraductal papillary mucinous neoplasm is an intraductal variant of mucinous adenocarcinoma. Next subheading is oncocytic neoplasm. It is of no consensus whether oncocytic carcinoma exists, and oncocytic appearance is a common change encountered in different salivary gland tumor. So in the past, carcinoma consisting entirely of oncocytes were frequently diagnosed as oncocytic carcinoma. But now, molecular studies have shown that many such tumors represent oncocytic variant of other salivary carcinoma. So it is not classified as an independent entity now, and it is put it into the category of emerging entities. So it is now a emerging entities, that is oncocytic neoplasm. Concluding the article, so the authors in this article concluded the various highlights of WHO 22 classification of salivary gland lesions as molecular pathology of salivary tumor has seen numerous advances in recent years. Question remain concerning the classification of neoplasm with morphologies matching known type, but the tumor lacking the recognized molecular alteration. As more molecular and clinical data accumulates about these tumors, such questions may be answered and tumor classification adjusted accordingly in future editions. Thank you for the opportunity.
Right. Till we give everyone the chance to type their questions, let's share this. Yes, Dr. Puyan.
Yes, thank you, Dr. Kriti, for the well-described presentation on the second part of the paper. I would like to invite all the residents and postgraduate students around the world to join this program. Oral Pathology 360 provide a direct connection with well-known authors around the world to communicate with them and share your presentation with them. And it's a great opportunity. Please follow the web page of the Oral Pathology 360 to join this invaluable program.
Yes. You can scan it. I will also add it in the description. You can also just go to the website and look under the tab participate, and you will find the form. Fill the form. It needs to be filled up by the faculty member. Please remember the faculty member who will then be the guest moderator for the session will have to fill up the form and give the names of two residents, and then we will get in touch with you. And just like today, where Dr. Krishna and her two residents are with us, you will be with us presenting a paper with us in the future. Yes, with that, let's go now to the questions.
Okay, great. Thank you again, participants, for staying with us. Let me quickly ask you, Professor Scalova, a question about my problem. I have always, nervous when I have a carcinoma of salivary gland tissue with cribriform appearance. How can I differentiate an adenoid cystic carcinoma from a cribriform adenocarcinoma when we have a carcinoma of minor salivary glands? how we can differentiate them using both H&E staining microscopy slide or immunohistochemical staining.
Thank you, Puyan. Adenoid cystic carcinoma is a aggressive tumor. It's a horrible tumor, actually, for patients. So it's very important to distinguish, to make diagnosis properly, and distinguish low grade types of invasive carcinomas in the oral cavity, which may have cribriform structures. However, I am uh, very convinced that in most cases, you can do correct diagnosis of adenoid cystic carcinoma on H&E. You can.
Okay.
You look at the nuclei. The nuclei are basaloid. They are angulated. There is higher mitotic or let's say proliferative activity than usually in other low-grade invasive carcinomas of the oral cavity. Uh, the what should help? I sometimes, in very difficult cases where I am not quite sure, I may use this MIB1, Key67, yeah, confirming proliferative activity. And then what you should do, you should look for biphasic pattern of adenoid cystic carcinoma using either P63, P40, and CK7, and you see better the structure. I'm still speaking about H&E and really morphological pattern. And then, of course, if you still do not know, there is a fish probe against MIP, and that's the best, of course. I use it in consult cases and in small biopsies. You may use surrogate marker MYB, which is not very. Dr. Krishna agrees with me. It's not very reliable. I do not like it too much. And basically, I'll try to really to compare morphology. Cribriform adenocarcinoma is tumor which has a nice distinctive morphological pattern. In addition to cribriform, in so-called cribriform adenocarcinoma, Puyan, you have also glomeruloid structures, you have solid areas with a detachment of the solid nests from the fibrous septa. You have features. Nuclei are pretty much different between adenoid cystic and cribriform adenocarcinoma. Yeah. So that's somehow my question, my answer.
Mhm.
Yeah. But it's
Great.
difficult and it must be done properly, of course. Yeah.
Thank you very much. It seems that both H&E staining and ancillary study, including
Mm.
IHC study, especially proliferative activity, in addition to the assessment of mutation, will be helpful in complicated cases.
Yeah. True. Yes, that's it.
Great. And Dr. Krishna, do you have any comment or question? Please share with us.
Dr. Skolova, can you tell me about the precursor, the comment on the precursor lesion terminology that has been now been frequently used in this classification system? Like some precursor lesions, like sclerosing polycystic adenoma, has been considered as a precursor lesion for apocrine intraductal carcinoma. So,
Okay.
because
Yeah.
precursor lesion in oral pathology is quite confusing already.
Yeah. Okay. Okay. If I understood properly the question is about precancerous or pre-malignant potential of sclerosing polycystic adenoma, and I have to say yes. I have seen cases, and it's already been published that these are so rare. There are couple of cases in the
Okay.
literature, but it may happen that sclerosing polycystic adenoma may develop into the intraductal carcinoma, intraductal carcinoma apocrine, apocrine type, and in our last paper, where we collected experience with more than 30 cases of sclerosing polycystic adenoma, we had one case where in one tumor there was focus of sclerosing polycystic adenoma, focus of intraductal apocrine carcinoma, and salivary duct carcinoma with androgen receptors and invasive growth pattern. This tumor is exceptionally rare, of course, but we should, I think, important thing is to know that that sclerosing polycystic adenoma has this pre-malignant potential and should be removed from the patient. So that's how it is. The other, if I can add a little bit about intraductal carcinoma, which was discussed very well by Kritti as a controversial entity. I know very well. I was fighting. I mean, during the editorial board meeting when we produced this fifth edition of WHO classification, I was fighting really against the term intraductal carcinoma, and our suggestion of our group was to establish the name intercalated duct carcinoma, invasive or non-invasive, and to put all these apocrine stuff away, and it would be clean. But at the moment, that term again is controversial. We now know that intraductal carcinoma is definitely heterogeneous group from biological point of view, and also molecular point of view. Molecular background is pretty much heterogeneous. So that's what I can say at the moment about intraductal. And there are coming new papers about this topic, and uh, uh, we we have two papers actually now submitted to Virchow's archive, and one more paper is going to be on its way quite soon about invasive transformation, invasive carcinoma arising in intraductal carcinoma. So let's see the changes in the sixth edition.
Okay, great, great. Thank you very much. And we have comments about the intraductal carcinoma from Professor Joss Hill. Thank you, Professor Joss, for joining us. He
Hello,
explained
Joss.
that yes, he explained that the hallmark morphological pattern of the intraductal carcinoma is a predominant cystic structure surrounded by smaller ductal proliferations. Do you agree, Dr. Escalova, with this microscopic description by Professor Lee?
Absolutely, I agree, but I would say that it's still we have to have in our mind that it's a heterogeneous entity. It's sometimes hallmark, but sometimes not. Yeah, and we even did not discuss this Justin Bishop's paper where he or his group showed that in intraductal carcinoma, myoepithelial layer, which is abdominal and luminal layer, have the same molecular underpinnings. So basically, there is a question if intraductal carcinoma is really in situ lesion. Probably not. It may be biphasic tumor because abdominal and luminal layer have the same molecular underpinning. So we are on the very thin ice at the moment. And there
Mhm.
is another question. If I can move, just ask what happens molecularly when we observe a transformation of
Yes, exactly.
intraductal carcinoma into more aggressive pattern. I don't know. There are mutations, but
Mhm.
there are so many. We still do not know exactly. There are more mutations in it.
Mhm.
Yeah. So I'm sorry, I am not at the moment competent to say anything better.
Okay, now, and another question that Dr. Gupta ask us about the is there any parameter for classification of salivary gland tumors for a classification of oral pathology lesions in general. I'm not sure what does it mean that
Mean.
which parameters do you mean? I think you explain in your paper that you use morphological and also it's a study in addition to emphasizing on the genetic alteration of the tumors to well classify the carcinomas of oral cavity.
Puyan, you are absolutely right. I would not be able to answer better than you did. Basically, my long time opinion about salivary gland tumor classification is that you have to have absolutely the best. Uh, H&E background. First and last is the H&E diagnosing.
Great.
Then you use a little bit of immuno, and of course molecular testing is absolutely wonderful, but molecular testing, I do a lot of molecular tests for salivary gland tumors because it's available in my lab, and my most cases are consult cases, so I like to help. Yeah, so in a general pathology practice, of course, not everybody has molecular lab to be used. So we need to rely on H&E and a little bit of immuno. But molecular testing helped us a lot to establish clean entities, to improve the criteria for diagnosing of the different entities. And it can be used also for research, of course, but also for diagnosing of abnormal, atypical, or let's say metatypical. I don't know if you understand what I mean. There is a new approach of expanding molecule, expanding histological findings, which can be diagnosed as a simple entity based on molecular testing. For example, there is a paper about metatypical adenoid cystic carcinomas. They look differently, but they have canonical fusion MIP and FIP. Yeah, so can be diagnosed as adenoid cystic carcinoma. Similarly, mucoepidermoid carcinoma with very unusual features. Again, Justin Bishop quite recently described unusual subtypes of mucoepidermoid carcinoma, Bortin tumor-like ciliated pattern. Myself, I describe oncocytic variant of mucoepidermoid carcinoma. And for diagnosing such tumors, you use molecular techniques, and it's important. But basically, for 90% of cases, you use H&E and experience. A good microscope and microscope connected with brain.
Mm.
That's my recommendation.
Great suggestion. Great suggestion. Thank you. And we have a question from Dr. Akshay. There's a suggestion that can we consider adenosquamous carcinoma, which is a variant of a squamous cell carcinoma, can we consider this entity as a as a part of the salivary gland carcinoma, adenocarcinoma, NOS, not otherwise specified. Do you agree with
Um,
this suggestion or not?
Well, Dr. Akshay, I am not very uh, mature. I think I do not have very good answer. I believe that adenosquamous carcinoma is a histomorphological variant of squamous cell carcinoma. It has nothing to do with, it should not be classified as salivary gland carcinoma, NOS. I think we should stay with adenosquamous as a variant of squamous cell carcinoma. But
Great.
Maybe I'm wrong. I do not know.
Mhm. Great. And Dr. Krishna, I think we have lost Dr. Krishna. She's breaking up. Dr. Krishna, do you have any comment or you would like to share any question with Professor
Yeah,
Salman? I
I am
think we
back.
have 5 minutes, about 5 minutes.
Uh, Ma'am,
Okay.
yeah, just thank you for giving the hope that histopathology, that is HE, is still the backbone for salivary gland. Thank you for the support for saying that good microscope with a brain is still required in salivary gland lesion diagnosis.
Thank
Okay.
you
Okay.
for the comment. Thank you for comment. I really believe I
Uh,
have so many different diagnostic opportunities using molecular laboratory and immunohistochemistry. But basically, you really need to know what to order in the lab. And so I'm really sure that the most important is to have good knowledge from literature, good knowledge from your microscope, from histomorphology, and then you have a opportunity to narrow your different diagnostic consideration much better. Yeah.
Okay, thank you. And I would like to ask one more question. I think it might be the last question about the oncocytoma, Professor Skalova. You know, we have made
Thank you so
several
much for that.
oncocytic carcinoma so far, and oncocytoma, and in duology classification 2022, you propose that there is no true oncocytoma or oncocytic carcinoma. You mean that all of these lesions we have made so far are oncocytic changes of other entities? Do you agree?
Dr. Puyan, I am very happy that you opened that you put this question on table, because this is probably the most important question of the whole meeting today. Look, uh, oncocytic carcinoma has been an entity in a fourth edition. Now it's not. It's not there. The decision was unanimous, made by unanimously made by editorial board members. Why? Because in most cases, not in all, but in most cases, fully oncocytic malignancies. Look, we are not speaking about oncocytoma. Oncocytoma is an entity, but oncocytic
Okay.
carcinoma, in most cases, these malignancies, composed mostly of oncocytic cells, do represent either oncocytic salivary duct carcinoma, which is very aggressive, or oncocytic mucoepidermoid carcinoma, which is a low grade, low aggressive. So it's very recommendable to distinguish oncocytic malignancy into these two major categories. The other possibilities are rare. There is oncocytic intraductal carcinoma, yes. There is oncocytic foci in actinic cell carcinoma, but it's very rare and it's not the problem. But oncocytic mucoepidermoid and oncocytic salivary duct carcinoma should be distinguished. And there is one more sentence. If you do not have a laboratory with equipment, with molecular testing to provide evidence of mammal 2, CRTC1 or CRTC3, mammal 2, to make diagnosis of oncocytic mucoepidermoid carcinoma, if you do not even have androgen receptors to provide evidence of salivary duct carcinoma, you still stay with writing it's a malignant tumor composed of oncocytes, carcinoma, oncocytic carcinoma, and OS, correct? And that's
Okay.
possibility. We still have possibility to make this diagnosis. But the major major intention of authors of fifth edition is to push to diagnose salivary duct carcinoma oncocytic and oncocytic mucoepidermoid carcinoma correctly. So
Okay.
that's how it is.
Okay, great. Thank you very much for your well descriptive reply. And I think we are at the end of the meeting, and it was very informative for me, and I'm sure that it was very informative for the all participants. Let me ask our residents, Dr. Kriti, Dr. Dipanjali, do you have any comments or questions you would like to share with Professor Skalova?
Ma'am, I want to ask about the cribriform adenocarcinoma. Uh, it is aggressive in nature, that is written in the article we mentioned, but hotspot mutation is present in that. But hotspot mutation is of good prognosis. So, how can this be defined?
Yeah, yes. Okay. That's the question about molecular underpinnings and about biological behavior. Both cribriform adenocarcinoma and conventional polymorphous adenocarcinoma are relatively low grade. They are not extremely aggressive. Cribriform adenocarcinoma is more commonly associated with lymph node metastasis. All pathologists should be familiar with existence of this cribriform subtype of polymorphous adenocarcinoma. With this mutation and non-mutation, hotspot mutation, yes, hotspot mutation in PRDK1 is more common in conventional type polymorphous adenocarcinoma, which we used to call PLGA, yeah, before. While cribriform adenocarcinoma is mostly associated with fusions in PRDK1 to 3, yes, but we should not be so much bothered by this. If you remember, a couple of years ago, mucoepidermoid carcinoma, and there were questions how it's possible that fusion positives cases have better prognosis. That does not make sense, but it's true. Yeah. Basically, my answer is morphology. You should be able to see orphan any eyes, yeah, nuclei in cribriform adenocarcinoma, and write to your report, uh, look, there may be a risk of development of cervical lymph node metastasis. Be careful. Yeah, but that's it. So that's my answer.
Thank you, ma'am.
You do not need molecular
Okay,
testing.
thank you.
And if I still have a audience now, I would like to express my real appreciation and real gratitude. You are just wonderful, Dr. Puyan, Dr. Mandana, Dr. Krishna, and both residents. You are doing so good job for everybody. It's a pleasure to be collaborating with such active group of people. This is I really appreciate. Thank you so much for inviting me.
Thank you.
It's very kind of you, Professor Skalova, to contribute to this program. Let me ask Dr. Dipanjali, do you have any comments? Are you with
Hello.
us?
I do not have any comments as such, but it was a great opportunity for connecting with such a experienced author, Professor Elena, ma'am, and on the platform of Oral Pathology 360, for us residents to experience this is indeed a great opportunity.
Thank you.
Great. Great. Thank you very much again, Professor Escalova, for being with us, Dr. Krishna, for supervising the talented residents, and Dr. Kriti, Dr. Dipanjali. It was a great pleasure to have you, and we are
Thank
ready
you.
for the next step, Dr. Mandana.
Yes, here we are.
Okay.
Ma'am, even
You,
Hazare sir is online, actually.
Yes, I just saw that. Yes,
yes, yes, we
yes.
are still online. let's before giving the online certificate of appreciation, let me announce the next interactive online journal club with authors. We will have a very interesting meeting with Dr. Sven Niklander from Chile, and also Professor Hunter accepted our invitation to join this meeting, and we will have students, residents from Cancer Institute Hospital, supervised by Dr. Safwan. I would like to invite you to join us in September, on 27th of September. And I would like to give the certificate of appreciation to the uh, panel. First of all, Professor Scalova, no
Thank
words
you.
need to express our appreciation to you. Thank you for your great contribution.
Thank you.
And also, the next one by thank you, Dr. Krishna, for being with us and guiding the
Thank you.
residents. And the next one, I would like to thank Dr. Dipanjali for being with us. Thank you for your great presentation and well organized PowerPoint. And
Thank you, sir.
you're welcome. The last but not the least, I would like to thank Dr. Kriti for
Thank you, sir.
joining us. Thank you for your well designed and well descriptive presentation. And
Thank
thank
you
you
so much.
again for the participant for being with us. I hope to see you soon in the next program in September. The
Yes.
stage is yours, Mandana.
Yeah. Thank you so much, Dr. Puyan, for another very interesting and very well conducted session. Thank you, Professor Skalova. It was indeed a great pleasure and honor having you with us. It really made a difference. Thank you so much.
Thank you.
And thank you, Dr. Krishna. Of course, you are with us often, and thank you so much. And of course, the lovely and active residents, I wish you all a great success ahead. And I hope you will do many great things. And the audience for being with us and for taking the time, typing your questions, being with us, attending live. It's amazing. It's always amazing to have everyone. Do join us again, whether it is for our OP Tuesdays or for the next Journal Club. Thank you so much. Have a wonderful time. Be safe. Take care.
Bye bye.
Bye
Bye bye.
bye. Bye. Bye.